Thank you, Dr. Amit and AIOS, for giving me this opportunity to speak in this instruction course, which is on debates of glaucoma and trying to understand the correct way forward. So my topic is Mitomycin-C versus 5-fluorouracil for Bleb Needling. I do not have any financial interest in any of the products in this presentation. So what is Bleb Needling? Bleb Needling is nothing but a surgical intervention which is aimed at revising Bleb architecture by lysing subconjunctival fibrotic tissue that interferes with successful filtration and hence causes Bleb failure or glaucoma surgery failure. Bleb revision surgery has been advocated as early as 1941, but it was popularized further in the 1960s. But needling has become more popular after the advent of antifibrotic agents or antimetabolites. So Bleb anatomy basically Bleb has loculations within it, which can be either diffuse or localized. Margins of these loculations within a Bleb are formed by bands between either the conjunctiva and the episclera or the conjunctiva and the sclera or subsclerally itself, which separates the main area of filtration from the surrounding areas of the Bleb. And lysis or puncturing of these bands of fibrous tissue to increase the area of filtration and improve the functioning of the Bleb constitutes needling. Just basic visual inspection of a Bleb may not give us much idea regarding functioning. And apparently flap Bleb may be functioning well, and a centered and a Bleb with good height because of loculations may not function well. So careful slit lamp examination, gonioscopy in all cases, very important along with the IOP measurements to know which Bleb is functioning or not. And ASOCT also helps in finding out cystic spaces. So basically this is a photograph. If you peel a Bleb and you see the inner surface, these are the loculations which you are seeing. And this is a photograph of a Bleb showing us the ring of steel phenomenon, which happens because of fibrosis of the edge of the Bleb, which does not allow aqueous to flow further beyond and limits its filtration. So what are the indications of Bleb needling? Basically, Bleb encapsulation. If there's inadequate control despite an elevated Bleb, if there's a flat Bleb with a scleral flap which is visible, any Bleb which requires topical AGMs to control IOP, this aesthetic Blebs. Important to note is gonioscopy is absolute must for any patient before we decide to that patient needs to undergo reading, because a patent internal stoma is important for us to give the best possible outcome. So these are just a couple of videos which I talk about, which are thanks to Dr. Manish. Here you can see these are slit lamp based videos that after anesthesia and betadine cleaning with a 26 gauge needle using side to side movements of the needle, you are trying to break the loculations which are there within the Bleb area, and therefore you try to increase the Bleb filtering area. In the second video which you see here, you can see there is a gradual increase in the Bleb height because there is egress of aqueous from the anterior chamber into the subconjunctival space, showing that there is lysis of the conjunctival bands. Apologies for not having an operation theater based video system. So use of antifibrotic agents most commonly used are 5-fluorouracil, which is nothing but a halogenated pyrimidine analog. It is a competitive inhibitor of thiamidate synthase. It gets incorporated into DNA and RNA of actively dividing cells, causing defective protein synthesis and interferes with the cell growth cycle. Important point to note is that cells only in the synthesis phase are affected, but allow other cells to proliferate once the 5-FU exposure is over. In comparison, Mitomycin-C, it is an antibiotic derived from Streptomyces cespitosus, which is an alkylating agent, cross-links DNA, inhibits synthesis of protein, inhibits mitosis, and acts on all stages of cell replication cycle, inhibiting both dividing and resting cells. So theoretically, it is a more potent antimetabolite as compared to 5-FU, and it possesses potent anti-angiogenic properties as well. So in the context of Bleb needling, which should be our antifibrotic of choice? MMC or 5-FU. We'll look at these in certain headings like dosage, technique, what is the IOP control, what are the success rates, use of anti-glaucoma medications post-needling, complications, and risk factors. Now to assimilate all these, we have to look at obviously literature. There are numerous articles available which have comparative and non-comparative studies, retrospective and prospective studies, which have given varying results. So actually the data doesn't point us into one particular direction, and it's difficult to compile considering there are so many studies which are not standardized, as the techniques are different, dosages are different. But a particular meta-analysis which came out in 2020, which compiled all these studies, whether comparative or non-comparative, has helped me in reaching to some endpoint. So basically, dosage of 5-FU is basically 5 milligram in 0.1 ml, which has been used by all studies. Usually injected at the end of needling procedure, either in the inferior conjunctiva or 90 degrees away from the bleb, and usually with a 25, 26 or 27 needle, usually after the procedure. While topical Mitomycin-C has been used in various dosages, 0.02 milligram, 0.04 milligram, and also in some studies 0.4 milligram per ml, which is quite a higher dose and caused a slightly higher number of complications as not advised. Timing of injection again has varied. Many studies have injected 5 to 10 minutes before needling. Few studies have injected during needling as well, and usually injected away from the bleb area. Needling procedures ideally should be done in the operation theater itself, because it gives you better control of the procedure, gives you better handling. And in case there is some sort of complication like hemorrhage into the anterior chamber, sudden AC shallowing, will give you more control compared to slit lamp for needling. But few studies which I have mentioned have also done slit lamp needling, so it's ultimately a surgeon's choice. IOP control of MMC versus 5-FU showed a modest drop in both, which is almost equivalent. Higher baseline IOP resulted in higher IOP reduction in both groups. If you see, however, the topical Mitomycin-C, which is shown in blue, numerically has shown a slightly higher IOP reduction compared to 5-FU. Success rates. Most studies evaluated success rates as complete success. That's a 20% drop in IOP, or IOP less than 21 millimeter of mercury without medications, or qualified success, which is the above with medications at the last visit, which could either be 1, 2, or 3 years. Again, the success rates for both are almost similar, with Mitomycin-C showing slightly better complete success rate compared to fluorouracil. However, there are studies which have showed equivalent success rates for both as well. IOP medications post-needling, however, have shown a statistically significant reduction up to 1 year of follow-up in both Mitomycin-C and 5-FU. Is there any impact of pre-needling bleb morphology? Again, varying results between different studies. However, some have shown that if there's a bleb with greater central bleb infection and higher bleb, it will associate with slightly higher chance of success. And a moderately injected or vascularized bleb had a higher chance of success compared to a whitish ischemic looking bleb. Complications. Again, this is very important for us. Mitomycin-C, because of its complications like ciliary body damage, coronary decompensation, is a little more fearful as far as complications is concerned. However, as far as the studies post-needling, they have not shown us much difference between 5-FU and Mitomycin-C, with conjunctival hemorrhage remaining seen in almost 10% of cases with Mitomycin-C, and slight increase in hypotony and serious choroidal detachment. But however, these are not statistically significant, only numerically different. And studies with longer duration and larger sample size have had more complications. And what are the possible risk factors for surgical outcome? So timing of needling, early needling, which is I think quite commonly known to all of us, will have better outcomes, and this was seen in both groups. So any needling which is done 2 months to 6 months post primary trabeculectomy will have better outcome. Eyes which have had an increase in number of needlings, 2, 3, 4 needlings, have shown worse outcomes at final follow-up. And eyes which have had immediate drop, IOP drop post needling, if you discount any sort of bleb leak or choroidal effusion, have shown better outcomes in the long term. So as I said, again, looking at all these factors, as I said, what was a take-home or take-clinic message? Data is not very robust. Data does not give us a very clear idea in giving us an obvious answer whether Mitomycin-C or 5-FU for bleb needling is better. However, either one of them should be used for all our needlings, preferably in the operation theater. Needling, as we know, is moderately effective in prolonging the life of a bleb. Mitomycin-C and 5-FU are both potent agents which improve success. MMC theoretically has slightly better success rates, but slightly more complications, so should be done carefully. Ideally should be injected, I think, 5 to 10 minutes earlier compared to needling, so that there's enough time for absorption, so that when you start needling, there is no chance for the Mitomycin-C to go directly into the anterior chamber at that point of time and cause issue with either corneal endothelial damage or with ciliary body toxicity, which can be extremely dangerous and can cause large visual morbidity in such patients, and we should be careful of that. And early needling, 2 to 6 months, gives us better outcomes, and fewer needlings or fewer procedures will give us better outcomes. These are my references, and thank you, Amit, and thank you, AIOS, again, for giving me this opportunity.